Welcome, everyone. I am super excited about this one. My name is Jessica Shortall. I am the Strategic Partnerships and Coalition Lead for the Integrated Harm Reduction Team at the R Street Institute, coming to you live from the Twin Cities, and super excited to have here with me Shoshana Walter, Pulitzer Prize finalist Shoshana Walter, whose book I devoured, Rehab, An American Scandal, to talk about the book and talk about the state of treatment and recovery in this country, the good, the bad, the ugly. The book is just a very quick overview, uses case studies of 4 different individuals to look at so it's very micro, but to look at our big systems of care for treatment for specifically in your book for opioid addiction, primarily. And of course, like these 4 case studies, which Shoshana, don't represent every experience in addiction and treatment, but they're actually so well chosen and told to represent some pretty big themes in that you see in a recent interview. You said how the system is really not working as intended. So welcome. I'm already just diving right into it, but excited. Do you want to explain a little bit about your journalistic background and work before we dive into all of this so I don't get it wrong?
Sure. And thanks so much for having me. I really am so glad to be here. I'm an investigative reporter. I work at the Marshall Project, which is a nonprofit focused on investigating our criminal justice system. Before that, I worked for about 11 years at Reveal from the Center for Investigative Reporting, where I first started working on reporting on our addiction treatment system. I kind of stumbled into it, and I can talk about that at some point during the interview. But yeah, I'm happy to be here, and this has been a long time in the making.
And I will just say, speaking of reveal, I put it in the wrong. I'm going to put in the chat a link to one of your pieces that you did at New York Times Reveal, which was actually a major catalyst for some of our work on the integrated harm reduction team to look at how perinatal use of medications for opioid use disorder are treated and how those mothers are treated in pregnancy and after giving birth, sometimes having their children taken away for taking prescribed substances. And so when I get a second, or if one of my colleagues can drop in the chat a link to some of our work that kind of riffed on that reporting you did. So we're very grateful to you for that. So the biggest overarching theme that stood out to me in this book was your assessment that some elements of our systems of treatment and for drug addiction are overregulated, while other systems don't draw enough scrutiny. Is that an accurate takeaway?
Yes, definitely. Yeah, part of the book goes into the history of Suboxone, our gold standard addiction treatment medication for opioid use disorder. And and when Suboxone was first launched in the United States, I'm sure this is not going to come as a surprise to many of the people attending this webinar today, but it came along with many restrictions on patient care, patient limits, oversight by the Drug Enforcement Administration, required training. And on top of that, because Suboxone was kind of like this brand new medication being launched by a private pharmaceutical company, the company, Reckitt Benckiser at the time, also received this market exclusivity from the FDA. So 7 years of no generic competition. And all of these things combined really created a lack of access to this medication during a really crucial time period in the epidemic. And on top of that, we've for a long time in this country, due in part to our nation's first federal drug law, there has been this separation between medical care and our addiction treatment systems. And following the passage of the Harrison Narcotics Act in 1914, this law basically prevented doctors from prescribing narcotics to patients who are known to be addicted. Thousands upon thousands of doctors were arrested and criminalized for giving narcotics to addicted patients. And so ever since then, and this is a little bit of an oversimplification, but ever since then, there has been this separation between medical care and addiction treatment, and also a stigma among many doctors and healthcare providers towards treating addicted patients. And even though some of those barriers to care have been taken down, there still is that stigma. There's still not enough infrastructure for healthcare providers to provide addiction treatment. And there's still fears of the Drug Enforcement Administration um, coming in and criminalizing doctors, criminalizing pharmacists for making medications like buprenorphine available. Um, One of the people that I follow in this book is Dr. Larry Lay in Indiana, who was one of the first prescribers in the nation to offer Suboxone to patients. And he found a number of ways to get around this patient limit that was preventing him from treating all the people who were coming and knocking on his door, desperate for help. And because of that, he drew the attention of local law enforcement and the Drug Enforcement Administration, and they pursued a criminal investigation of him and ended up raiding his clinics, arresting him and his entire staff. There was a news conference in which they called him the Pablo Escobar of Suboxone. And all of his patients were suddenly cut off from their medications. Many of them relapsed, some of them overdosed and died. And he eventually went to trial and was acquitted. And this was after months and months of undercover agents going into his clinics, pretending to be patients in need of addiction treatment. And after that, all the charges against the other employees of Larry's practice were dropped. But when I met Larry, he passed away a couple years ago now. He had lost everything. He himself had a history with alcoholism, and he relapsed. He lost his medical license, and he was just desperate for someone to tell his side of the story and for some acknowledgement of the role that he played in providing this medication with few barriers during a time period when very few doctors were willing to prescribe it. And and as over time, as I got to know him, he gave me access to his entire criminal case file. These are records that are typically totally confidential and off limits to reporters. And so I was able to review all of the investigative records, and all of the undercover agent footage, and really see for myself what this clinic was like and how the closure of all these clinics impacted Larry's patients.
I mean, it was that moment in the, oh, did I, no, I thought I was muted. That moment in the book when they shut him down that I kind of gasped because that those folks had nowhere else to go. And this medication is keeping them, helping them stay stable, employed, parenting, healthy, giving them space and time to work through whatever they need to work through, right? And just knowing that those people, some of them would have to go back to the illicit street supply because they'd go into withdrawals.
100%.
And that supply is incredibly dangerous. And just knowing that those closures would cause people to die was really hard to read. So that's the kind of highly regulated side. And your book it talks more about buprenorphine. Suboxone is a brand name there for a formulation, but some about methadone as well, which is even more highly regulated, cannot be prescribed by any doctor and dispensed by any pharmacy. You have to get it through a specialized, lay people would call it a methadone clinic, opioid treatment program. But like I said, I mean, is that an accurate observation that then in the Chris story, and you'll explain who these folks are, and in some of the other stories in the book, you talk about it looks like those systems that they are sent to, sometimes by our criminal justice system, do not face even close to the same level of scrutiny and regulation on how they're providing care. Is that accurate? Accurate
Yeah.
assessment?
Yeah, definitely. I mean, Chris Kuhn is one of the people you just mentioned. He's another person that I followed in this book. And he was a young middle class white guy from Louisiana um, who started using opioids when he broke his ankle during a three-wheeler accident when he was 15 years old. And that's kind of started off a period of adolescent experimentation that turned into an addiction during his early adulthood years. And his parents were very desperate to do something. And they sent him to a 30-day program, which seemed like a good program. And Chris finished it. He came home and then he immediately relapsed. Such a common story with these 30-day programs. And he ended up getting arrested and then court ordered to this program called the Senecor Foundation in Baton Rouge, Louisiana. And, what Chris was told about this program is that he would be there for 2 years. He'd receive medical care and counseling, and he would get to live and work and save up money for after he left treatment. But when he arrived, he learned fairly quickly that all he would be doing for the most part was working. And Senecor at the time kind of operated its program as like a temporary labor force, contracting patients out to private companies, including at one point Exxon and Shell oil refineries. And the patients were not paid for any of this work except for a pack of cigarettes per week. And so Chris learned very quickly and early on that he would be working up to 80 hours per week, unpaid, in these really difficult manual labor jobs, laying asphalt in the broiling Louisiana heat, rebar, cleaning up after LSU football games, building scaffold chemical plants. Um, and, he was supposed to receive counseling and treatment and medical care, but it was almost impossible to receive medical care, and he rarely received counseling. I mean, I spoke with his one of his former counselors who said that basically she would track him down when he was in bed after getting home from a long night of work and just pop her head in and say, "How are you doing?" And he'd say, "Fine." And then she'd like mark that off as a counseling session. And so this was, basically the sole form of treatment going on there for Chris and many others. Many people were injured in the program and didn't receive adequate medical care. Chris was one of those people, and he ended up getting kicked out of the program early. He thought that he would be sentenced to prison because he didn't complete this diversion program, and the judge instead gave him probation. So there was a more positive outcome for Chris, which we can talk about later. But I initially learned about Chris while working on this podcast series with my former Reveal colleagues called American Rehab, and it was a series about Senecor, but also about the many programs like it that exist across the United States. And the origins of these programs. And what we found about these programs is that they're often unlicensed. They often, there's no oversight, there's no regulation. No medical care is typically ever provided, including psychiatric medications or evidence-based medications like buprenorphine or methadone. Um, and they're often faith-based. And so there's kind of this massive regulatory loophole that exists for these types of programs that are often utilized by the courts or used by patients who don't have insurance or need longer term care. And so this is basically their only option. And when we were looking into Senecor, Senecor is unusual because it was licensed at the time by the state. And so there were all these regulatory records, years and years of records of complaints and inspections. And I was kind of surprised to see that there were complaints about abuses and exploitation in this program going back years. And there were never any real consequences for the program. And this is another thing that I saw again and again with treatment programs that were misusing their patients. Um, you know, uh, Basically, regulators didn't rarely looked into the most exploitative practices in these programs, and even when they did, programs were given the opportunity to issue a plan of correction. There was there was really never any enforcement of that. It was pretty toothless, and so the programs were allowed to continue. And Senecor ended up shutting down their work program, and they very much otherwise remain in business to this day.
I listened to that series before I started this job at R Street years ago and was just enthralled by it. It's great reporting. Yeah, and so that, another case study in your book is centers around this woman, Wendy McIntyre, who's a just passionate, very passionate, I'd say, citizen advocate to try to shine some light on a group, but it centers on one facility in California that, to your point, would have some pretty big violations. They had non-medical staff giving out, dispensing medication. You had folks in very dire circumstances that were supposed to be checked on every 30 minutes and weren't checked on for hours. And just the sort of corrective action plan would set the whole thing. To me, I wondered, is there's many reasons for that, I'm sure, but one of them is a system that's so desperate for treatment beds. Is it hard to enforce and shut places down and then have nowhere for people to go? That's not to excuse the treatment that happened there, but is that part of the picture too? I wondered.
I suspect that's part of the picture. And another thing I noticed too is that regulations often are not necessarily evaluating um, the quality of the treatment or
Mm,
what treatment programs are actually doing. They're often evaluating what the treatment program's policies say they're doing. Um, and uh, and that's not necessarily an indication of what's actually, unfortunately, going on in a program.
mhm.
This program that you were just mentioning, it, I'll explain who Wendy is and then I'll say a little bit about that program. But Wendy McIntyre is another person that I followed in this book. She's a longtime advocate for patients in California, and she kind of became something um, of an activist with some unusual methods after her own son died of an overdose in a sober living home. She began investigating and trying to root out corruption in for-profit treatment facilities in California. And, when I met her, I just could see how passionate and fastidious she is. Um, and also, I learned that, she is so impassioned and kind of obsessive in the pursuit of justice that she can sometimes take it a little too far. And some people might say, like I learned that several treatment programs had filed restraining orders against her because of her investigations. And when I was reporting on her story, she was arrested for felony kidnapping for trying to help a teenager escape an abusive facility. So she really, really believes in what she is doing. And the first time I met Wendy in her home in the San Bernardino Mountains, I walked into her house and, the floor was just carpeted with boxes and boxes of her investigative records. She collects everything. And so I was able to read through all of those files. And she had spent years investigating this one facility in the San Bernardino Mountains that had a pattern of over medicating patients to the point of impairment. Um, One patient, he had fled the facility in the snow and fog and disappeared. And only months later, his remains were found down the side of the mountain. And this mistreatment just continued for years and years. There were several patients who died in this program after receiving cocktails of medications that records showed were not prescribed to them, and that doctors later said had been ordered for those patients using prescription pads without their authorization. And Wendy was sending thousands of emails and making hundreds of phone calls to local law enforcement and to regulators to get them to do something about this place. And, after years of this, it never happened. The facility ended up shutting down on its own after the owner told me that he went into debt after a series of wrongful death lawsuits. So there was really never any significant action taken against this facility by regulators or law enforcement.
It is just an interesting contrast of where the regulatory apparatus kind of focused in your case studies, focused its significant energies, like you said, DEA agents posing as patients in this clinic that was prescribing Suboxone, which is considered a gold standard treatment for opioid use disorder, versus what you're describing here. One thing you mentioned about Chris before he went to Senecor is that his first stint in a treatment facility was 30 days. So I was, learned a lot. You talk in the book about how insurance for treatment tends to work, with much treatment being covered for a 30-day block of time. And of course, every person is different. So, and we understand, insurance companies and treatment facilities have to make these sorts of decisions. But what did you find regarding the outcomes of this kind of typical 30-day stint? And are there financial incentives and motivations that surround that model?
Yeah, I mean, so these 30-day programs, and sometimes it lasts a few months, but oftentimes a maximum of 30 days. And what I found in my reporting for this book is that without ongoing support after someone leaves a 30-day program, relapse is very likely. In fact, someone who completes a 30-day treatment program is much more likely in the year following treatment to overdose and die than someone who has failed to complete that program at all. And of course, someone who's incarcerated, the risk after they leave a stint of incarceration of fatal overdose is also exponentially higher than it is for the general population. And so I think what happens in these programs is people are abstinent from their substance of choice or the substance they typically use. And then their tolerance level goes down, and then they leave that program. And without that support or without an adequate plan or ongoing care, they relapse, but using the same amount of substance that they had previously been used to using. And now that amount is too much, and it leads to overdose, and sometimes that can be deadly. And so I think that these programs actually end up fueling relapse rates and use in due to that short-term care. And there was another person that I followed in this book, April Lee, who also went to a 30-day program early on in her addiction. April's background is a little bit different from Chris's in that she grew up in poverty. She's Black. She at that point had been separated from her children, and she really went into this program with very few resources to rely on, both during the program and after she left. And that's another big takeaway from my reporting for this book. I learned a lot from researchers about the importance of recovery capital, this mixture of internal and external resources that people need in order to enter and sustain recovery. And that can be social and community support, but it can also be economic support, having a job, housing, transportation, food, adequate health care. And someone who goes into recovery lacking these resources is much more likely to fail following treatment, or maybe not even complete treatment without those resources in hand. So I think that this really speaks to the limitations of our treatment system and our healthcare system, that people really need that recovery capital in order to enter and sustain recovery, and they're just not getting it, especially in these 30-day programs.
I was fascinated to learn that a job has developed, wherein some folks have the job of following up with people who've completed their 30 days, find out if they've returned to use, and recruit them back into treatment. They get a commission for that.
Yes.
Um, and yeah, I mean, as you point out, right, reduced tolerance from either having been incarcerated or been in abstinence-based treatment, or taking medication for opioid use disorder and having that cut off or taken away, really increases people's risk. And I feel like I'm kind of representative of the average American, right? I'm not one of our policy scholars at our street, so I'm a lay person, and I just did not understand that until kind of shockingly recently. that this kind of, cycling in and out. And our friend of our street, Dr. Jeff Singer at Cato Institute's in the Q&A. I'm going to see if we can get the chat opened up for people to be able to drop things in there too, but has put in the Q&A a couple resources about sort of abstinence but based programs, 12 steps, et cetera, that are from the evidence among the least effective and can also lead to these kind of risks of overdose and fatal overdose.
Yeah.
And return to use is a normal part of that recovery journey for some people. I don't know what the numbers are, but it's not a straight line for many people, and it's not a one and done for many people. But I took from the book that it seemed like some facilities are actually building that kind of return to use or relapse, as some people would call it, into their business model. Is that
Yeah,
right?
yeah. I would say this, 30-day program really significantly proliferated with the passage of the Affordable Care Act. Insurance funded programs as a business really became viable. And so all these programs have proliferated, especially in California and Florida, but all over the country that, basically design their programs around maximizing billable services, which makes sense from a business perspective. And treatment programs certainly should be able to remain open and function. But what I found is that a lot of treatment company owners are really frustrated by this limitation imposed by insurance companies, often of 30 days. And then there are other programs that actually have built that high relapse rate following these programs into their business model. The treatment company that I was talking about earlier that was over medicating patients, I mean, I interviewed this owner, and he referred to it as a cycler. Patients come in, they complete the program, they graduate, they leave, they relapse, and then they come back in. And he is among many treatment company owners who employed staff who would call up former participants, find out if they relapsed, and then if they had, especially if they had good high-paying insurance policies, re-enroll them in the program. And that was essentially their aftercare program, rather than helping to provide that ongoing support or finding a way to set up that ongoing support. They were finding out if someone had relapsed, and then, oh, that means you need to come back into treatment. And then they get to start over all over again, starting with detox, which is the highest paying level of care, all the way down.
Switching gears a little, you mentioned April, whose story really struck me as a mom. And we got to look through her story with issues that might impact women more, women with substance use disorder. I mean, not to mention that one part of her return to use was that she was sexually assaulted and didn't have the supports in place to deal with that trauma. But you touch on a number of barriers that would likely impact women and especially mothers more in getting access to and being able to stay in good evidence-based treatment. So childcare, for example, the way that, back to your previous reporting, maybe mothers are treated in accessing medications for opioid use disorder. Can you talk about those barriers a bit?
Absolutely. Yeah. I mean, we know that treatment programs that allow women to bring their children have the best success rates for families. We know that women who give birth and babies who have neonatal abstinence syndrome, the best care and best outcomes for that mom and that baby is for them to remain together. About 70% of women struggling with addiction have children. And yet, what I found in reporting this book is that the number of treatment facilities that we have catering to women with children have actually declined over the course of the epidemic. This was acknowledged as a massive problem during the crack cocaine era. Lawmakers were talking about it. They were concerned enough about it to push states to spend a certain percentage of their funds on programs specifically for women, and most states did not live up to that guideline. And so now, years and years later, um, from the beginning of the opioid epidemic, despite this knowledge that we have the massive concern it seems to have generated at one point or another, the number of such programs catering to mothers has declined. Now it's something like 3% of facilities nationwide allow women to bring their children with them, and about less than 5% of facilities provide childcare.
3% allow parents to bring kids along with them.
That's right. Yeah. And so, for women, one of the top reasons cited for not going into treatment is a lack of childcare. Then you have programs that also decline to treat certain women, like pregnant women. So there's discrimination there as well. But, for someone like April, who, she was struggling with addiction, she had childhood trauma, then she was sexually assaulted. It triggered major mental health issues, but she was a single mom of three, the sole caregiver and breadwinner. And she just could not take that time away from her kids. There was nowhere for her to take her kids in order for her to get the help that she needed. And then eventually, when things really got so bad that she realized she was unable to function in her addiction, she did find an old friend of her mother's, had her children come stay with her while she tried to figure it out. And then when she returned, her kids were gone and they had been removed by the child welfare system. And it took her years to get them back, which has created issues for her entire family, for her children.
Another generation of trauma, right? It was
Yeah.
hard to watch her story through the pages of the book because she was so committed. She was born to a mother with substance use disorder, and she was so committed to doing things differently. And then to watch her not be able to get that care for herself, then it was like, it seemed to me that then she was using in a kind of strategic way to be able to keep parenting, to keep,
Yes.
keep herself like, sort of stable enough to keep parenting. 3%, less than 3% allowing parents to bring kids in with them. It was just heartbreaking to see. And right, that next generation now suffer the trauma of separation from their mom and seeing her go through that.
Exactly. Yes.
Yeah. Oof. Okay, we're going to circle back to medications again, like methadone and buprenorphine, which are considered, and Dr. Singer put some of this in the Q&A, gold standard forms of treatment. We talked about this a little bit, but any additional barriers to access that you saw in your reporting, whether it's geographic or based on people's socioeconomic or, status or other characteristics, what did you see?
Yeah, I think that currently there are still major barriers to access. The X waiver is no more, but there are still not enough providers considering the people who could really utilize this medication. And there's still kind of a fear among prescribers and pharmacists that the Drug Enforcement Administration could take action, or that it could draw the attention of the Drug Enforcement Administration. One of the stories that I ended up cutting from my book is the story of this pharmacy in rural West Virginia, one of the places hardest hit by the epidemic. Rural counties have the least amount of access to these medications. And this pharmacist was filling prescriptions for buprenorphine, not Suboxone, but buprenorphine, one of the few pharmacies in the area actually doing so. But because of the fact that patients were driving from hours to get there because there were no pharmacies willing to fill these medications, that was viewed as suspicious by the Drug Enforcement Administration. And they took away his license and they shut the pharmacy down. And he eventually was cleared, but it had a detrimental impact on his business. And I
For
think this
sure.
is still a real fear among providers that,
That's
um,
going to have a chilling effect, I imagine, to other providers who can't afford to lose their livelihood over one type of medication.
exactly.
Yeah. When you mentioned rural areas, there was a pretty recent study, I'll try to find it in the Journal of American Medical Association, that found that 1 in 3 people getting buprenorphine via telemedicine, which is so important in rural places, had a break in access in the past year due to issues at the pharmacy.
Wow.
So even when that, pharmacy access exists, it's not working the way that we would hope it would be intended.
Right. Absolutely.
Any specific populations that it seemed to be more impacted by these access barriers for
Yeah.
medications?
I mean, I think that it's white communities that tend to have greater access to buprenorphine, and Black and indigenous communities that have less access to these medications. Also, the duration that people remain on these medications, there's a racial disparity there as well. And we know that the longer someone remains on these medications, the more benefits they see from them. And this is the case too. There's racial disparities around who has access to treatment in general, who enters treatment, who completes treatment. Black and indigenous communities are far less likely to complete a treatment program than white communities are. And I think that has a great deal to do with the recovery capital that someone has and the resources and stressors and challenges that someone might have outside treatment, which is really where recovery is going to happen, not necessarily inside a residential treatment program, but outside treatment once someone is back into their life. What does it look like, and what kind of supports do they have once they're there?
Right. And then I go back to you saying at the top of the hour, this when Dr. Larry Lay's office was raided and he was arrested, his colleagues were arrested, that he was being compared, called the Pablo Escobar of Suboxone, right? So go back to that issue that's a fascinating analogy to be made, that the folks, trying to get out to communities, and he was mostly, I think, prescribing to relatively well-off community, I think, is that right? But are being compared to drug dealers because we have this, I don't know if it's a uniquely American thing or what, but this kind of funny thing of assuming that a medication to treat opioid use disorder is not a real solution. It's another quick fix, or replacing one drug with another, we hear a lot. Um, so I think, that plays in as well. And we saw that in your book with so much scrutiny on folks providing this evidence-based treatment, maybe more so than abstinence-based rehab centers or sober living homes, that are kind of operating however. Speaking of which, stigma and attitudes within the treatment industry, and how these various programs choose to approach recovery. Um, Lived experience, your book is a testament to it, is such an important part of what we talk about in harm reduction and treatment and recovery and wellness, generally. And the voices of people with lived experience really need to be front and center, as they are in your book. We tried to do that as well. Because it's sort of the nothing about us without us call for not making systems that don't work for people. But I noticed a kind of interesting paradox in your book, um, or dynamic, where there were some of these less regulated kind of treatment facilities, let's call it that way, Senecor, the Above It All in California is called, that you had some individual people that had lived experience, especially having gone through that particular system. And some of those folks seem to have outsized weight in how that program was run and in deciding what constitutes the right kind of treatment, or what a person with substance use disorder needs. What's your take on that, on how well the treatment industry, or it's not really one industry, right? Various fragmented pieces integrate evidence with the perspectives and opinions of individuals. Like, how can we do that in a way that makes sure that that stays front and center, but in an evidence-based way, rather than a kind of, this worked for me, therefore everyone should do it this way?
That's a really great question, Jessica. I mean, when I'm hearing you talk about this, I'm thinking a lot about the story of Donovan Doyle, who we talked about earlier. He was this 21-year-old who, through his parents' insurance, went to that program in the San Bernardino Mountains. He was over medicated there, became super unstable there. It was, aside from this medication that he was put on for detox purposes, ostensibly, the program was mainly 12-step based. The counselor that he was working with was really about confronting him and getting him to break down, and accept that he needed help, even though that's why he went there in the first place. But he was so debilitated in this program that he actually started wetting the bed at one point, and the other patients were making fun of him. So he was moved into a room by himself, and he just um, got worse and worse. And the program never, there was never any, there was briefly discussion in the program, or a suggestion by a concerned employee in the program that they find another placement for him, that maybe he needs a different level of care or a different program. The treatment company owner totally shut that discussion down, and he was communicating with Donovan's family, and telling them, like, Donovan calls you and says he wants to leave. Don't listen to him. He can't be trusted. He doesn't know what's best for himself. Um, and that's such a common dynamic, that families are told not to trust their loved one who's struggling with addiction. And so Donovan's parents listened to this treatment company owner, as Donovan was suffering in this program. And he ended up, as I talked about earlier, he ended up fleeing after an altercation with his counselor into this snowstorm, this thick fog that was covering the mountain, making it impossible to see. And he ended up, disappearing, and only to be found months later, his remains found months later over the side of the mountain. But I think, what the research shows is that someone's personal motivations for recovery are incredibly important, a sense of self-efficacy, that they have the power to make changes in their own lives, that they're really steering the ship. That's so important for someone who wants treatment, who's entering treatment, who wants to get better. And oftentimes the dynamic in these programs is, you can't trust yourself, listen to us, we know what's best for you. And it's actually very disempowering. And that can be really detrimental for some patients.
Yeah, that story was heartbreaking to kind of watch his decline from afar, knowing how it ends up, right? Because the book opens with that search and finding of his remains.
Yes, the
Um,
parents
I'm going
were
to jump into the
heartbroken.
Q&A here, where Dr. Singer has asked, have there been any, to your knowledge, medical malpractice cases against negligent rehab clinics? Did you come across any?
There have been a lot of lawsuits against negligent rehab clinics, yes. In fact, several of the patients who died in this facility that I've been talking about filed wrongful death lawsuits, and those were settled. In a couple of cases, there was even an admission by the rehab center that they had been negligent in their care of these patients. Um, but yeah, that seems to be the main way that families are able to get some justice for mistreatment of their loved ones. And it's so heartbreaking and infuriating, because it often comes after the harm, the worst harm, death. I mean, there has to be a better way of providing people with care, so that families are not in the position of having to file wrongful death lawsuits in order to see some justice. And even with those lawsuits, it's still never enough, because someone has passed away.
Yeah. Did you in your reporting come across any examples in the policy space of lawmakers attempting or succeeding at putting some things in place that might help improve conditions in these facilities?
There have been a lot of attempts, in California in particular. I'm thinking about, there's a number of legislative proposals on the table right now. And then a number that have been attempted many times over the years to no effect. In California, outpatient programs are still not required to be licensed or certified. Sober living homes are not required to be licensed or certified. And advocates have been pushing for years to get these laws passed. And in fact, there was a bill that was passed that would have required licensure for outpatient facilities, and it went to the governor's desk and he vetoed it. So there have been many attempts, and there's still some of these bigger problems of regulation and oversight are not resolved. I mean, a huge number of these for-profit insurance funded facilities are located in Southern California. And currently there's only about 5 investigators in that region of the state that are tasked with inspecting and investigating complaints in these programs. So there's there's lengthy wait times for complaint responses and investigations. The results of those investigations are often fall far below what they should, especially when we're thinking about patients being given very powerful medications that in an interaction with each other especially can lead to death themselves. The oversight is just not there. And this is California, one of the main hubs of for-profit treatment in the entire country. And still, the oversight is very poor.
I can't help but when I feel sort of most cynical about this, wonder if, culturally, I wonder if we just have a kind of general agreement culturally that folks with substance use disorder, at least they're getting something, right? And to not dig too deep into it, which I find very upsetting. And as you show in your book, will hit very close to home to most Americans. But once you're in that, you're in maybe less of a position to advocate because you're in the throes of trying to help your loved one or yourself. Um, Going big picture, and it is, I will say, a little plug for harm reduction. Part of why, we think harm reduction mindset is so important in thinking about the big picture of substance use. It's not the only thing, it's not a silver bullet, nothing is, but the idea of building trust, building relationships, as you say, letting people set their own kind of path of what they're ready to do, what steps they want to take, feel like they need to take or ready to take, and to stay alive while they're doing it, seems like a pretty important piece of the picture. And it's not an explicit theme of your book, but I saw a lot of that show up in your book. Um, Going big picture. So let's talk about the federal budget. We're in the midst of some pretty big cuts to Medicaid. So wondering how you see those impacting. Boston University and UPenn researchers recently estimated that the impacts of the to Medicaid in the One Big Beautiful Bill Act will cause 156,000 people to lose access to medication for opioid use disorder, resulting in about 1,000 additional fatal overdoses every year. Are there other impacts you're seeing across the various types of treatment, recovery, rehab, what have you? Do you dig into that in your reporting, or did you come across that? What those sort of budgetary decisions mean?
Aside from the study that you just noted, I mean, I think that's very significant, and I think that Medicaid is the payer of addiction treatment for people with opioid use disorder, at least 50% of people with opioid use disorder. So that seems very significant to me. I think it still remains to be seen exactly how these cuts will affect individual states. Um, but I think there's also and that's just treatment. I'm also thinking about cuts to harm reduction services. But I'm also thinking about um, a lot of the more punitive policies and laws that are being passed across the country. A lot of states have been cracking down on homelessness, on and passing mandatory minimum sentences for fentanyl related offenses. And I think what we've seen in this country with our drug policies is that um, the longer someone remains in their addiction, the more marginalized they become, the more punished they tend to be, and there are collateral consequences from those punishments. Criminalization, that can impact um, someone's chances of overdosing. That can impact someone's ability to get a job and housing, loans, government benefits. So those policies have ramifications for recovery capital. Those policies make it more difficult for people to accrue the resources that they need in order to enter and sustain recovery. So I think that we'll definitely see some impact from those new laws and policies on people who are trying to recover. And how the treatment funding and harm reduction funding cuts play out, I still don't know. And I'm really looking forward, wrong word. I really am eager to find out how how this all plays out. And I know that people who have been attending um, my book related events are really worried about it too. I met one mom who told me that her son had attended 24 treatment facilities before getting on methadone, and methadone worked for him. And he's been on methadone for 8 years, and Medicaid is paying for his methadone. And so she's very worried. She's very worried about it. And, if people are cut off from those medications, it's as I saw in reporting my book, it can be detrimental.
Devastating even. Related, very timely question here in the Q&A from Harmony, asking, in your reporting, how did you see race and gender shaping who receives punishment versus treatment? And those are sometimes the same thing when you get like a Chris being court ordered to Senecor, but who receives punishment versus treatment in America's addiction system? And is there anything, what gives you hope for building solutions that center people of color?
That's a great question. I mean, I think that uh, there are definitely racial disparities in who is even arrested for drug-related offenses. And then that filters down through our criminal justice system. But then when it comes to treatment instead of incarceration, there are some places where there are drug courts and diversion courts um, that are specifically for the purposes of providing that alternative. And some of the criteria used for people to enter those programs can be discriminatory. But then once people enter drug courts and diversion courts, there's also a way that structural inequality can create poorer outcomes for people of color or lower income people. It's harder for it. Drug court and diversion court programs can be very difficult financially for people, and can take up a lot of time. And if you don't have the resources to spend your time going through a drug court program, then you're much more likely to fail. And sometimes you can end up with a longer prison sentence after failing a drug court program than you would have if you had just accepted a plea deal prior to entering that program. So there are all sorts of problems there. And then when there isn't a drug court or diversion court program available, like such was the case with Chris, his dad was able to hire a private attorney for him. That attorney was the one who managed to negotiate this treatment program instead of incarceration deal for Chris. Of course, that treatment program ended up being less than ideal. It was itself incredibly punitive, and it was really detrimental for Chris. But, people who have access to private attorneys, who can advocate for them in a way that public defenders are not able to, are often able to work out a better arrangement for themselves than people who have to rely on our public defense system, our overworked public defense system.
Q&A is open, folks, if you'd like to add anything else in there. And in the meantime, I'll ask kind of along Harmony's lines of questioning. Do you see promising ideas out there around approaches to substance use disorder? You mentioned some of them in the kind of closing pages of your book. Would love for you to share some of those with folks.
Yeah, yeah. Yeah, I mean, I didn't get to put much of this in my book, unfortunately, but as part of the reporting process, I was able to shadow providers at this bridge clinic program at Highland Hospital in Oakland, California, where I live. And this is a low barrier program at at a hospital that caters to people with Medicaid or no insurance. And a lot of their patients are unhoused individuals in Oakland. And their criteria, I mean, basically they accept anyone who needs care. And if someone relapses, it's not a reason to cut them out of treatment or kick them out of treatment. Instead, those people remain in care. And so I was able to spend a lot of time seeing these providers at work, and was pretty amazed by the results. There were patients I met who, you know, Highland Hospital is kind of hard to get to. I mean, Oakland has a public transit system, but it's not as great as some cities. And The clinic itself is kind of in a maze in this old, a little bit run down area of the hospital. It's hard to find. I mean, I had to like get directions every single time I visited, but still there were patients who, when they wanted to come in and see the doctor, they tracked, to get there. There was one patient I met who would go on a long walk to the clinic, and as he walked to the clinic, he would pick flowers from people's front yards and then present the receptionist with a bouquet when he arrived. And he was in his 60s. He decided that he wanted to try getting sober because he realized that he'd reached the age that his own dad, had been when he passed away, and unhoused person, living on the streets of Oakland. And he went to this clinic regularly for care. He was still intermittently using, but because of his ability to maintain that care, he was healthier than he would have been had he been cut off from treatment. Um, and I think the challenge for this clinic that I saw is they had a social worker there to help people um, access resources that they might need. But one of those huge unmet needs was housing. And there was just nothing that one treatment program could do to provide people with the housing that they need. And so I think that's a limitation of our system, of our healthcare system, really not necessarily a limitation that's specific to this program, but a larger limitation, and that our healthcare system is not able to give people everything that they need in order to live their healthiest lives.
So much resiliency you saw in the people you profiled and interviewed. My wish, I'm guessing yours too, is that we didn't require them to be quite so resilient. But it was, an honor to get to know some of these folks through the pages of the book. We are almost at time. Rehab is the book, American Scandal by Shoshana Walter. Super grateful to you for writing this book, for doing the work of talking to folks and really sensitively telling their complex stories of their lives. Really appreciate it. And grateful for you. Any closing words for us, Shoshana, before we head out? Where are you headed next on your book tour?
Uh, I'm not sure yet, but I'll keep you updated. No, I'm just grateful for the opportunity, and I'm really grateful for how engaged people are and passionate about this topic. I mean, I've been hearing from people all over the country, and that gives me great hope for this issue, the future of of treatment, and also I take great inspiration from the resilience of the people that I followed for my book too. I'm very grateful to them for being willing to allow me to share their stories. It's a great privilege. So thanks. I appreciate
Such an
it.
important conversation. Thank you so much for joining us, and thank you all for participating. We're glad to have you.
Yeah, thanks so much, everyone.
Take care.